Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clearwax. Thank you for joining me in my latest video using the iClearscope endoscope. And here we have a patient who attended with bilateral occluding wax plugs and also a thick layer of skin lining their entire ear canal and also their eardrum, which we also peeled. So this patient first visited me probably 5 or 6 years ago, and the period between their original visit and their next subsequent visit was about 4 years, and then it was 1 year, and now it was only 6 months since we last saw this patient. So this patient was interested to find out any possible reasons as to why they are having to attend more regularly over the course of the last 5-7 years. And one of the things that we discovered whilst talking to the patient was that during that time, their job has become increasingly more stressful, particularly in the last year or so. Now, how can stress lead to excessive earwax formation? Well, that's because one of the glands that produce one of the ingredients of earwax. So let's just remind ourselves, earwax is an amalgamation of dead skin cells that are shed from the outermost layer of skin that lines the ear canal, the epidermis layer. It could also be dust, dirt, loose hairs. So that's all your dry matter. And then you've got two wet matters. You've got sebum, which is an oily lipid secretion secreted by the sebaceous glands that are connected to the hair follicles, and also an oily sweat full of protein, which also contains lipids, and we call that cerumen really, and that's secreted by the ceruminous glands. Now, the ceruminous glands are a modified sweat gland, and it's slightly different to the more common sweat gland that we probably know about, which is the eccrine sweat glands. These are typically found on your brow and your body, and they secrete an oily, a salty, watery sweat to help thermoregulate our body temperature. So the sweat glands found in the ears are slightly different. They're what we call modified apocrine glands, and they're not induced by heat. They're not stimulated by heat. Instead, they're more stimulated due to emotional responses, more specifically the flight or fight response. So if someone is more stressed, it's going to stimulate these particular glands, the ceruminous glands, which will then produce and secrete more of this oily, lipidy, protein sweat, which can then amalgamate alongside the dead skin cells, the sebum, and any other dry matter like loose hairs, for example, to form earwax. So that's one potential reason, and that does kind of fit in with the patient's kind of time span in terms of how much more stressed they've been due to work pressures during this period of time. Another reason, but one of the things that can lead to a wax impaction is this layer of dead skin, as you can see that we're peeling away. So this skin is not migrating sideways from the eardrum to the entrance of the ear. Now, I can't recollect whether that was also the case many years ago when this patient first visited. According to my notes, no. But if the skin is no longer migrating, then there's no natural conveyor belt for this wax to be transported out of the ear. So the skin that lines the ear canal, as it dies and sheds, it moves sideways laterally from the deepest region of the ear canal, actually off the eardrum, towards the entrance. And as it does, any wax sitting on the surface of the dead skin is naturally transported out of the ear alongside jaw movements as the wax approaches near the entrance. Now, in their right ear, they had a mild attic retraction, so the top portion of their eardrum is buckled inwards, it's sucked inwards. Now, this patient has previously suffered from eustachian tube dysfunction. So the eustachian tube is the narrow orifice connecting the middle ear to the back of the nose, and it's got a dual function really. It's the pressure equalizer in the middle ear. We want the air pressure behind the eardrum to be equal to the air pressure in front of the eardrum. And it also serves as a drain pipe. So any fluid accumulation behind the eardrum, it allows it to drain away. So previously, this patient's eustachian tube was blocked, and it's normally the top part of the eardrum because it's the most elastic, and also the upper back region of the eardrum, what we call the posterior superior region. That also gets sucked in because in comparison to the rest of the eardrum, it's more elastic and less tense. And sometimes with the attic region, when the eardrum gets sucked in, it can also happen with the posterior superior region and also other parts of the eardrum. So it's not impossible for the rest of the eardrum, the pars tensa, the tense part, to be sucked in. It can do, but typically it's the pars flaccida, the top part of the eardrum, just on top of the short process of the hammer bone. So the short process, that spherical portion at the top of the hammer bone, also known as the malleus. But the inside of the eardrum, just like the outside, is quite sticky. So if it gets sucked in historically, it can stick to the portion of the hammer bone called the neck of the hammer bone. So when we checked this patient's ear pressure and mobility after the procedure, there was no negative middle ear pressure. So the air pressure behind the eardrum was equal to the air pressure in the atmosphere, which suggests that the eustachian tube is working and functioning just fine. So that retraction could have been an historic retraction, which has stuck itself, the inside of the eardrum. When it's got sucked in, it stuck itself to the neck of the malleus, and it's just remained there. Now, whenever you've got an attic retraction, you just got to be careful there's no skin ingression. There was some skin adhered to this patient's eardrum, which also kind of filled in that retraction, but it came away. There was no sign of a cholesteatoma. So similarly to the left side, remove the plug of wax, and now I'm just peeling away the skin. It's quite adherent. You can see it's not only coming away from the eardrum, but from the ear canal, but also the eardrum. So just going to re-enter. There's no attic retraction in this patient's eardrum. So I'm just going to mop up the entrance a little bit for the patient. So quite a few hairs at the entrance. Now it's going to go back in. Going to look at the eardrum. It looks nice and healthy. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.